speaker, Dr. Stephen Harrison, a renowned expert in fatty liver disease. For those of you who may not know Dr. Harrison, he completed his internal medicine residency and GI fellowship at Brooke Army Medical Center in San Antonio. Subsequently, he completed an advanced liver disease fellowship at St. Louis University. He is board certified in both internal medicine and gastroenterology. He's the past associate editor of Hepatology, and he's currently the associate editor of Alimentary Pharmacology and Therapeutics. He serves as a peer reviewer for over 20 medical journals and is internationally known for his studies in NAFLD-NASH with over 150 peer review publications. And with that, I would like to turn the microphone over to Dr. Harrison.
Thank you, Jerry. It's great to be here. It's great to be able to bring you an EASL update. The meeting is a little over a month past. It was in Paris, a lovely time to be in Paris. But quite frankly, what we saw at that meeting was a paradigm shift where hepatitis C had taken a back seat to fatty liver, and fatty liver really has come into the forefront of research and in a lot of ways, in diagnostic ways and in epidemiology data, and as well as therapeutic options. So we're going to go through that today, and we're going to have a focus on FibroScan application in fatty liver. There's also going to be some general data and general updates about fatty liver. And if we have time at the end, we can talk about some of the new therapies that were presented and talk through some of that, and hopefully have time at the end for some good question, good answers, some good dialogue. So without further ado, we'll jump right in here. So these are, oh, go back one. These are my disclosures. I think it's important to go through that just briefly. Okay, so we'll focus first on epidemiology and natural history. And again, I think it's important, you guys probably already know this, but it's important to reiterate that non-alcoholic fatty liver disease is really predicated on the rise in obesity in our country and around the world. And that's foundationally where we're getting this big surge in non-alcoholic fatty liver. The second biggest link is to diabetes, which is also linked to obesity. And so where you see obesity, where you see diabetes, you will have non-alcoholic fatty liver. And you can see in the bottom right-hand graph, this is a pictorial of the United States, really grabbed from the Center for Disease Control, their website, showing the increasing prevalence of obesity, particularly centered around the southeastern portions of the United States, but the Midwest as well. And this is a dramatic increase over the past 30 years, if you will. If you look to the left, you see most of the states had really less than 20% prevalences of obesity, with several in white having less than 15% prevalence of obesity. And now you have many states that are higher than 30, 35%. So where do we get non-alcoholic fatty liver? And in Texas, I use the phrase where tortillas meet genetics, because this is really about lifestyle and genetic influences coming together. And we'll show you some data in a moment where really the Hispanic ethnicity is at the greatest risk of this. And quite frankly, that's because of their genetic influence in the form of a PNPLA3 single nucleotide polymorphism. But this is my favorite Mexican restaurant on the left. It's called the Alamo Cafe here in San Antonio. And if you look at that picture, you see some tortillas coming out on the front, but in the back is how they're made. And if you zoom in on that, you can see on the scale is about 5 pounds of lard. And in the mixing bowl is just flour. So, this is how tortillas are made. It's basically processed flour with fat. And ultimately, the estimate, if you will, is that if you eat 3 of those tortillas on the front, that's equivalent calorie content to a loaf of white bread. So when you combine that with genetics, it's very easy to see that you can get an increased preponderance of fatty liver disease. So this slide, I have it here really to illustrate the point. At one point, the guy on the left was the world's heaviest man. He could not get out of bed. I did not personally know this patient. However, I could imagine that if you did a liver biopsy on him, he would be at significant risk for fatty liver disease. And I put in a hypothetical stage 3 fibrosis. The picture on the right is just me in my Army days, downrange in Iraq and Tikrit. The weapon of choice I used the very first day I got there was my Bard Monopty liver biopsy gun. I did that only to take a picture. I threw it away and then holstered my 9mm as mortar rounds started to fall in the background. So I quickly got rid of my little Bard gun and went with something a little bit more proficient in the war zone. But so just let's keep focused now on epidemiology. So this meta-analysis is really the best there is out there, looking at the overall prevalence of fatty liver disease around the world. And you can see on average about 25% prevalence, varies widely from 30% in South America to 13% in Africa. In the US, North America, about 24%. We'll drill down on that a little bit. And I want to do that by getting into some of the data that we've collected in San Antonio. Now, this has been presented in various iterations over the past couple of years at EASL and at AASLD. And the plan is actually to complete the study and hopefully present it as a late breaker at AASLD this fall. But as of this cut of the analysis, 771 patients had been enrolled prospectively. And just to give you a snapshot of the patients that we're enrolling, they are patients that are middle-aged, that are presenting for routine colon cancer screening. They do not have a history of known liver disease, nor do they drink alcohol to the extent that would cause them to have alcoholic fatty liver. They also can't be taking medications that can cause fatty liver. And I asked them if they wanted to know their liver health at the time they were having their screening colonoscopy. So patients were prospectively enrolled, and you can see ultimately we wound up with 465 patients that were okay for the analysis. And the analysis was basically a FibroScan with a cap and an M probe or an XL probe assessment, a multiparametric MRI in the form of a liver multiscan, MRI proton density fat fraction to quantify the degree of fat, and an MR elastography. And additionally, blood tests were done for liver enzymes, lipids, and glucose and insulin, as well as hemoglobin A1C. And if the patient had fat or fibrosis on any one of the analyses, the patients were offered liver biopsy. And so that's where we get this prospective prevalence study of both the severity of NAFLD and NASH and the prevalence of disease. So on this slide, you actually see the results. So on the first graph, you see two different colors. The overall bar graph tells you the prevalence of fatty liver, and where you see all the overall prevalence in 465 prospectively enrolled patients was 32%. Now, the darker red part, 17 that you see there, that's the prevalence of NASH. So the overall prevalence of NASH in a middle-aged cohort of patients presenting for routine colon cancer screening with a mean age of 56 years is 17%, with an overall prevalence of fat of 32%. So just throw that in the back of your brain. Now, when you look at diabetics, 71% of them had fatty liver, but 46% of them had NASH. So almost half of diabetics presenting to your clinic are going to be at risk for NASH, the more severe form of fatty liver. And if you look at ethnic breakdown, this is where the Hispanic ethnicity comes in the highest, almost 60% of Hispanics having fatty liver, but more importantly, a third of them have NASH. And then when you look at Caucasians, non-Hispanic, about 30% have fatty liver, but only 15% have NASH. And then if you look at African Americans, about 20% had fat, but only 3% had NASH. So what this is beginning to tell me is the at-risk groups here are the diabetics and the Hispanics, followed by Caucasian and then African American. Now the numbers get really small when you get to Asians. Prevalence there is kind of similar to a Caucasian population. And then the others would be Cherokee Indian, Samoan, and that sort. So we didn't break that down further. So what about the natural history? This hasn't changed significantly. I'd just like to highlight about 80% of people with fatty liver will grow old with their liver disease. They'll have isolated fatty liver or fatty liver with mild inflammation, and they're very unlikely to progress in their liver disease. However, those with NASH, and this represents 20 to 25% of fatty liver, are at significant risk of disease progression. In fact, what we know is that fibrosis portends a worse prognosis. So the more scar there is in the liver, the higher the likelihood of disease progression. So what about risk factors for NASH? Well, they're clinical and there's histologic. And really with clinical, the older you are, the higher the risk. If I polled a group of 20-year-olds and did the same study that I presented to you a few minutes ago at Brooke Army Medical Center, the prevalence of fatty liver and NASH would be significantly lower. But I did a study in 56-year-olds on average, and you see the prevalence of disease there. So it does rise with age. Male gender, I'll show you some epidemiologic data from EASL, but just it's consistent with what we know, and that is males have more fat, females have more severe disease. So, risk stratification for NASH, male gender is there, but as females age and go through menopause, the rate of disease progression advances quickly. So much so, in fact, that the majority of clinical trial enrollment is females. It's usually a 60-40 randomization. And then diabetes. Diabetes, as well as obesity, are really the two largest risk factors for NASH. I'll show you some data that hypertension is really gaining traction, is showing up over and over again as being a risk factor. And then AST-ALT ratio. This is probably the most important thing you can get out of this lecture today, and that is if you have an AST-ALT ratio of 0.8 or greater, that puts the patient at significant risk of NASH. So think of it this way. Fatty liver disease is an ALT predominant disease. It's usually 1.5 to 2-fold that of the AST. But as the AST rises, what we begin to see is more and more scar tissue is showing up, such that by the time the AST is equivalent to that of ALT, in other words, the ratio is 1, an example might be an ALT of 60 and an AST of 60. At that point, that patient has an odds ratio of 9 for having advanced liver disease. So if you don't take away anything else from this talk today, the higher the AST, the higher the likelihood the patient has NASH with more fibrosis. And then when we look at histologic, advanced fibrosis is the greatest risk factor for disease progression. However, portal inflammation and ballooning drive fibrosis development, and so we can't exclude them. In fact, you'll learn, if we have time at the end, that treating the drivers of fibrosis actually have a dramatic and profound impact on the resolution of fibrosis. So we always hang our hat on ALT, but remember, ALT can be normal in up to 60% of patients with NASH, and it can be increased in up to half of patients with NAFLD and no NASH. So ultimately, serum ALT alone is not predictive of NASH or the fibrosis level. It can't rule in NASH, and it can't predict NASH. The AST actually may be able to do that. We just need a little bit more data to support it. But the take-home point is, don't hang your hat on the ALT, because if it's normal, you can still have disease. In fact, we see that frequently in cirrhosis. So when we look at the histologic features associated with disease progression, fibrosis is the biggest predictor of mortality, followed by portal inflammation. Now, interestingly, fatty liver disease is classically known as a lobular inflammatory disease, whereas Hep C is more portal-based. Autoimmune hepatitis is more portal-based. However, as you gain fibrosis and you get to like an F3 patient, it's not unusual to have significant portal inflammation from NASH. Now, number 3 here is the diagnosis of NASH. Number 4 is ballooning. In theory, in my opinion, the diagnosis of NASH is number 3, mainly because of a problem we call collinearity. In other words, if you put in the diagnosis of NASH, ballooning, portal inflammation, fibrosis, ultimately into a multivariant logistic regression model, fibrosis always comes out ahead. Well, you don't get fibrosis without NASH. So there's a system of collinearity that's playing a role in why fibrosis pops out always ahead of NASH. But I think it's quite frankly just as important. Now, on the bottom right-hand corner, I think it's important on this slide to also point out the liver-related events risk by fibrosis stage, and this is relative to hazard ratios. So stage 1 disease, we see something less than 1, 0.63 to 8.91, meaning ultimately that there's no real increased risk of a liver-related event for a stage 1 patient. However, you begin to get significant hazard ratios at stage 2, suggesting to the FDA, for instance, that F2 patients are worthy of treatment because of the increased liver-related event rate that we see from this slide. So that's why a lot of studies involve F2, F3, and F4 patients. And stage 1s are often not included. Certainly stage 0s aren't, and non-NASH NAFLD patients are not typically included in NASH trial development. So there are lots of conditions associated with fatty liver disease. The most important ones are in red. The number 1 killer of a NASH patient is cardiovascular disease, and so that's pretty well known. However, we need to also keep in mind more and more data showing up that chronic kidney disease is linked to NASH, obstructive sleep apnea is as well, and for the gastroenterologist on the call, colonic adenomas, particularly right-sided lesions, are also linked now to fatty liver disease. So I wanted to bring out an abstract that was presented at EASL looking at risk factors for severe liver disease, particularly in patients with type 2 diabetes. And this was really based on 7.5 years of a Swedish medical registry, which covered 90% of the population, over 400,000 patients. And ultimately, what they showed was that the severe liver disease was 2.32 times more likely in patients with diabetes. And if you look at the table here, this is a table of the risk factors for development of severe liver disease. And I just want to point out a couple things, really 2 things. Blood pressure medications, yes, no, gave you an adjusted hazard ratio of 1.31, meaning that patients taking blood pressure medicine had a 31% increased risk of developing severe liver disease. Juxtapose that against male sex. Well, you had a 28% decreased risk of developing severe liver disease relative to female gender. So this kind of gets at what I was alluding to earlier. Males have more likely to have fatty liver, but females are more likely to have more severe disease. And the biggest risk factor on here is smoking. Smokers have a 78% increased risk of developing severe liver disease in the setting of diabetes and fatty liver. So we'll move on to the next slide. So here is another abstract that was presented looking at really the substantial healthcare costs among NAFLD and NASH patients. And here, this was a real-world analysis of the U.S. Medicare data from 2007 to 2015. And this study looked at 3,775 Medicare-insured fatty liver patients. And if you look at the bottom, the figure, there's a pre-cirrhotic index and a post-cirrhotic index. And ultimately, this was the annual mean cost stratified by diabetes status. And you can see that the cost of inpatient hospital visits increased by about 90%. But ultimately, when you compare diabetes in red to no diabetes, the costs are substantially higher in the setting of fatty liver disease. In fact, the mean average healthcare cost rose 71%. So let's move to diagnostic strategies and see what we can find here. And I'd like to use a case to illustrate this point. So this is a 56-year-old Hispanic female with obesity, type 2 diabetes, and ALT elevation. And a couple things I'd like to point out from this first slide. Look at the ALT and AST. ALT 70, AST 63, and alluding to what I said earlier that the AST-ALT ratio of greater than 0.8 is suggestive of advanced disease, here you can see a ratio that's close to 1. It's higher than 0.8. And the AST is close to that of the ALT. So right away, you could look at this and say this patient, 56 years old, Hispanic, postmenopausal, female, with type 2 diabetes and obesity, and an AST-ALT ratio greater than 0.8 is very likely to have advanced liver disease. So there are a couple non-invasive liver fibrosis tests that we can do to help stratify this patient's risk factors and probability of having advanced disease. I alluded to the AST-ALT ratio already, but one could also look at the NAFLD fibrosis score and the FIB-4 index or the BARD score. I'm going to take you through the NAFLD fibrosis score and FIB-4 on the next couple of slides, and then we're going to get into some of the elastography modalities, particularly VCTE or FibroScan. So what I've laid out for you on this slide is the components in the center of the NAFLD fibrosis score and the FIB-4 score. So the NAFLD fibrosis score, for instance, includes age, AST, ALT, platelet count, BMI, albumin, and impaired fasting glucose or diabetes. Now, the good news is there's a website you can go to for both the NAFLD fibrosis score and the FIB-4 where you can just put in these numbers and it spits out the answer. It spits out the number. So if you look on the left-hand side, NAFLD fibrosis score, if the number is less than 1.455, that rules out fibrosis with a high negative predictive value. Alternatively, if it's greater than 0.676, it predicts fibrosis with a less than optimal positive predictive value, although it's not too bad. And then the same thing with FIB-4, 2 different cut points, 2 different NPVs and PPVs. So let's go to our case. So I plugged in the numbers. You see the numbers in the center of your screen, and the calculator spit out the NAFLD fibrosis score at 2, and you look down at the category, and that puts the patient at a high probability of having F3 or F4 disease, which is consistent with what we thought at the beginning with the AST-ALT ratio. However, the FIB-4 is indeterminate, not very helpful. So what this tells me about the case is there's a high likelihood this patient has advanced NASH. However, the positive predictive values aren't the greatest, so we need to do additional testing. However, if the test were negative, there's such a high negative predictive value that we don't need to pursue a further workup. So having said that, let's go forward to talk about the next part of the workup here. And I'm waiting for the slide to advance. Okay. So before I do that, had forgotten I had a slide in here that looks at the positive predictive value and the negative predictive value of each of these scoring systems, whether it's AST-ALT ratio, BARD, FIB-4, NAFLD, fibrosis score. And you see the PPVs ultimately aren't that great. The negative predictive values are. And when we focus on the two tests that we just looked at, again, you see if the tests are negative, we can rule out disease very, very favorably. If the tests are positive, well, we still need some work to do. And ultimately, that gets us to FibroScan. And you guys, I'm sure, know a lot about FibroScan, but it is a non-invasive quantification of two physical biomarkers of the liver within a 10-minute examination. We're going to look at CAP, which is controlled attenuation parameter. This is quantification of ultrasound attenuation. It gives us an idea of how much fat is in the liver. And then there's also liver stiffness, which is basically obtained through a VCTE measurement, and it correlates with the extent of fibrosis. There are two probes, an M probe and an XL probe. XL probe obviously is for those that are heavier patients, and the machine actually tells you which probe to use when you put the probe on the side of the patient. Now, there are three different devices that you could use. The oldest is the 502 Touch you see here. Then the one that looks like R2D2, the 530 Compact, and the newest kid on the block, the 430 Mini. So this is what a report looks like. In blue is the controlled attenuation parameter number, and we'll talk a little bit more about what those numbers mean in a minute. On the right-hand side is the KPA, or kilopascal, and you see here it's 3.5. We'll also talk about what those numbers mean in a minute. But ultimately, those are the two most important numbers on this scan. The other thing that you're going to want to look at is this thing called IQR median. And you really want that to be less than 30% to provide you with what we consider an accurate test. All right. So having said that, let's move forward. The way that I like to use FibroScan is to stratify patients, screening all my fatty liver patients. And if I have a high CAP score and a high stiffness score, that puts them into the category you see here that's in yellow or red, meaning F2, F3, F4 disease, linking back to what the FDA has mandated for the treatment of fatty liver, that being F2 or greater fibrosis for the majority. There are some studies still including F1s, but mainly those are F1s that are at high risk of disease progression, and we're trying to get some safety data from the F1 population. But as far as treatment goes, really focusing on the F2 or greater population is what we're aiming for. So here's another abstract from EASL that looked at transient elastography for the screening of liver fibrosis in a population. And it was a cost-effectiveness analysis using prospective databases from 6 countries in Europe and Asia. And ultimately, there was no selection bias found. A liver stiffness measurement of 9.1 correlated to advanced fibrosis, meaning F2 or greater disease, with a decent AUC of 77. Now, there was also a mean incremental cost-effectiveness ratio for risk stratification, and ultimately, transient elastography screening pathway was found to be a highly cost-effective intervention and ultimately found to save dollars in the long run at excluding patients that did not need a workup. So putting it all together, here's the way I look at this. This was a pyramid I published a couple months ago back in Journal of Hepatology. You can get this from the journal. But ultimately, there's a high likelihood of NASH with fibrosis, an intermediate and a low likelihood. And the independent factors that predict this high likelihood of NASH and fibrosis are age greater than 50, Hispanic, diabetic, obese. So just think about our 56-year-old Hispanic diabetic woman. Patient ended up having advanced fibrosis, and so her AST was 63 in this situation in the pyramid, ASTs greater than 40 are linked to more advanced disease. AST-ALT ratio greater than or equal to 1. You could dip down to 0.8 if you would like. There's also data to support that. And then you have the FIB-4 and NAFLD fibrosis score that are in the high risk range. And then there's intermediate risk. These guys, are more like 50-50 chance of having disease. Age greater than 40, well-controlled diabetic, obese, hypertension. The stiffness score is greater than 7, so it's a little lower, although still in the abnormal range. And the AST here is greater than 20. This is a patient that if you're on the fence about, I would pursue a workup. If the patient wanted to try diet and exercise, again, that's a fair way to move forward. And those that have a low likelihood of NASH, you see here. So what about novel therapies in development? Where are we headed? Well, the pathogenesis of this disease is incredibly widely varied and multifactorial. It's complex, to say the least. There's involvement from the microbiome in some patients. In some patients, it's mainly driven by free fatty acid flux from adipose tissue. In some patients, there's upregulated de novo lipogenesis in the liver. And in some patients, there's dysregulation of mitochondrial function and of immune-mediated cell function, ultimately all leading to activation of this yellow stellate cell that I show you here. And that stellate cell is important in laying down the collagen. Now, before I move forward, it's important for me to tell you that the liver likes to regenerate. It likes to heal itself. It's a lot like the skin. If you cut your skin, you form a scab. That scab allows new skin cells to grow across the cut and heal. And once you're completely healed, the scab falls off. The same exact thing happens in the liver. We don't call it a scab. We call it fibrosis or collagen deposition. And that's because those stellate cells, which are normally quiescent, sleepy cells that don't do anything, when they get inflamed, when the liver gets inflamed, chemical messengers, in part through hedgehog signaling ligand pathways and others, activate these stellate cells, and they begin to lay down that collagen, that framework, that skeleton that allows new liver cells to grow. And once they've grown, then the collagen gets chewed up by the fibrinolytic properties in the liver. However, if you never take away the insult for injury, go back to the skin. If you always cut the skin in the same spot every day, the scab never heals, it just gets bigger. The same thing happens in the liver. You continually lay down scar tissue, and the liver never has time to heal itself. So paradoxically, cirrhosis is a result of a normal wound healing response that's gone unchecked because of constant injury in the liver. So having that in mind, how do we go about treating the disease? Well, this is a slide that shows ultimately the 4 phases of clinical trial development. Now, we have 5 studies in phase 3. We have over 20 studies in phase 2 and another 20 or so in phase 1. We don't have any FDA-approved treatment yet, so therefore we don't have any studies in phase 4. But ultimately, the future looks incredibly bright for non-alcoholic fatty liver disease. There are a number of studies underway to treat this disease, and I show you here the NASH pipeline for 2018. Those, let me go back, somehow I skipped over that. Those in yellow are what currently are in phase 3. We have several drugs, 5 different studies looking at phase 3 trials right now. And in red are those that are being studied with cirrhosis, in green, non-cirrhotic. So we have a nice sampling of both cirrhotic trials that are here or coming and non-cirrhotic trials. So I mentioned already that there were 5 studies underway. There's a study with obeticholic acid that's in phase 3. That's an FXR agonist. There's one with elafibranor, which is a PPAR alpha delta agonist. And there are 2 studies actually with selonsertib, which is an ASK1. And that Stellar 3 is in stage 3 patients. Stellar 4 is in cirrhotics that are well compensated. And then cenicriviroc, which is a CCR2/5 antagonist, actually is also in phase 3. So we get this slide advancing here. Let's see. So ultimately, the question comes up, what can I do for NAFLD patients today, short of getting them in a drug trial? Another way of saying this is, how can non-invasive assessment help me in clinical practice? So let's talk about that first, and then we'll get to lifestyle modification. Slides are just a little slow in moving forward, so bear with me. So the two major focus areas for you in your clinical practice are better stratifying patients according to disease severity and lifestyle modification. So we're going to first talk about better stratifying your patients. And the first thing we're going to focus on is a recent publication that moved just right past me there for a moment. So this is a recent publication that highlights ultimately FibroScan in the U.S. Now, for several years now, we've had published data with FibroScan in Asia and Europe, and I've had some question about what those cutoffs should be. Are they the same? And now for the first time, we have a very elegant study looking at U.S. NAFLD patients. This was done by the NASH CRN, an NIH-supported organization. And in this particular study, prospectively done, 393 patients with NAFLD underwent VCTE within 1 year of liver histology or liver biopsy. And this was published in what I call the Blue Journal, Clinical Gastroenterology and Hepatology, online ready in April of this year. So here's what I like about it. And this is really looking at KPA and comparing F0 to 2 versus 3 to 4. And you see the AROC here at 0.83, meaning this is a good assessment. If you look at sensitivity, the threshold is 6.5, and you have a sensitivity of 90% or 0.9. That's very good. You have a high negative predictive value, meaning that if your threshold for your patient is less than 6.5, it's very unlikely that they have advanced liver disease. So that's important. Now, when we look at specificity, and again, F0 to 2 versus 3 to 4, look at that threshold, 12.1 now. Now, we don't have a wonderful positive predictive value, but you have a nice, what I call the Uden's index, which is a blend of a good positive and a good negative predictive value. And the specificity here is 90%. So ultimately, we begin to say, okay, if it's less than 6.5, not so bad. If it's more than 12.1, that's really bad. And the balanced priority here is around 8.6, which gets me back to the pyramid that I showed you earlier. And at that pyramid, I said if the KPA is greater than 8.5, that's the group that's at the greatest risk for NASH with fibrosis. Now, again, when we focus on F0-3 versus cirrhotics in F4s, here we get even better AROC curves of 0.93 with a sensitivity of 12, meaning 12, not a sensitivity of 12, but a KPA of 12 and a sensitivity of 90% and a negative predictive value of 99%, meaning that really you can rule out cirrhosis if the KPA is less than 12.1. But that also gives us a very high sensitivity. Specificity is 14.9, again with a high negative predictive value and a high specificity and a balanced priority for determining cirrhotics from non-cirrhotics of 13.1. So now I want to move to CAP, and this is really critical. I want you to take away a lot from this. So ultimately, when we're saying no fat versus any fat, the ROC is 0.86 and the threshold is 263, meaning if it's less than 263, very unlikely to have fatty liver. Now, what gives you the ideal positive predictive value here and specificity is 353. Now, remember, this only goes to 400, but if you're above 350, you can almost bank on the fact that they have fatty liver. The balanced priority is 285. This is what I use in my clinical practice, is a CAP score of 280 or greater. It tells me the patient is very likely to have fatty liver. If it's less than 280, I'm less enamored with that. If it's less than 260, 240, almost assuredly they do not have fatty liver disease. Okay, so one final EASL presentation. This looks at really focusing on liver stiffness measurements to help us with the presence or absence of esophageal varices. And you have to go back to the Baveno 6 criteria. This has been published. There's also some extended Baveno 6 criteria that combine platelet counts with liver stiffness measurements. And the extended Baveno 6 criteria said, you know what? If your liver stiffness is less than 25 and your platelet count is greater than 110, that patient is very unlikely to have esophageal varices. And ultimately, this study looked at NAFLD cirrhotic patients, and it looked at a platelet count greater than 210,000 and a liver stiffness measurement less than 25,000, less than 25 kPa, using the M probe and the XL probe. The focus I would like for you to have for this slide is the bottom right-hand graph. This is using the XL probe. There was a training set and a validation set. Ultimately, between 46 and 65% of patients were able to spare themselves an upper endoscopy. And in doing so, you only missed esophageal varices needed to treat of five patients and 2 patients in a percent-wise format. So very few patients would be missed if you use these criteria. So this is what I hang my hat on. The platelet count is greater than 110. The liver stiffness measurement is less than 25. I feel very confident that that patient does not have esophageal varices that would need to be treated. So what about lifestyle modification? Again, I go back to a pyramid. It seems like I like pyramids these days, but ultimately weight loss of greater than or equal to 10% makes everything better. Fibrosis, NASH, ballooning, steatosis, all gets better. And that should be the target for our patients. The problem is most of them can't reach this goal. And if they reach the goal, they don't maintain the goal. And a lot of people have pontificated as to why this occurs. Here's my own thought about this. So here's something else you can walk out of this lecture today knowing. There are 525,960 minutes in 1 year, and I just sucked up 60 of them. So I hope you got something out of it. But ultimately, if you visit your doctor 15 minutes 4 times a year, that's 1 hour a year, 60 minutes. That represents 1/100th of 1% of your life space. And let's go back to our case. Our case was a 56-year-old Hispanic diabetic female. And I'm going to tell her she needs to lose 10% of her weight, and she needs to change her lifestyle. She needs to eat less, run more. Those are 4 words I use over and over again. She needs to modify her diet and increase her exercise. And I'm going to ask her to do that, and when she comes back to see me in 3 to 6 months, she needs to have lost weight, dramatically changed her lifestyle. And I'm going to do all that and have the audacity to do that in 1/100th of 1% of her life. This is why most people don't lose weight and maintain it. This is why The Biggest Loser never has a reunion. There's no reunion of The Biggest Loser because they always gain the weight back when they go off the television show. But what we do know from this slide is that weight loss correlates to the frequency of clinic visits. This may be why the placebo group in studies is so high, because they're seeing us very frequently in follow-up visits for their studies. So ultimately, this is published now in the guidelines, the guidance document that I was fortunate enough to be a part of, published in the AGA and AASLD publications. A combination of a hypocaloric diet, meaning you reduce your total caloric intake by 500 to 1,000 calories a day. You include moderate intensity exercise with that diet gives you the best likelihood of sustaining weight loss over time. Now, we got a few minutes. I just want to give you a quick update on what was presented at AASLD. I'm just going to hit the highlights. This is MGL3196, a selective thyroid hormone beta agonist. And what you found here is a significant reduction in liver fat, a significant improvement in liver enzymes, significant reductions in atherogenic lipids to include LDL, lipo(a), ApoB, as well as triglycerides. And ultimately, the 36-week paired liver biopsy data will be coming out according to a press release at the end of this month. So we'll be able to know what this drug actually did on histology with 36 weeks of treatment. But so far, the preliminary data looks good. This is NGM282, which is a non-tumorigenic FGF19 analog. This study was done by me. It was ultimately 19 patients had paired liver biopsies 12 weeks apart. What you see is a significant reduction in liver fat. In fact, 60% of people normalized liver fat in 12 weeks. 60% of people normalized liver enzymes in 12 weeks. And that resulted in 40% of patients improving fibrosis in as short as 12 weeks. And about 84% of patients improved their NAFLD activity score. So more to come, but this really set the foundation for showing us that NASH is dynamic. NASH can improve in as short as 12 weeks of treatment. And so more to come on what this means for the field. And ultimately, there's a slide I'd like to show real quick on GRMDO2, which is a galectin-3 inhibitor. This was used in 162 patients with NASH, cirrhosis, and portal hypertension. And ultimately, what this showed is that if patients do not have varices at baseline, that using this drug actually improved hepatic venous pressure gradient values. And this highlights a couple things to me. This tells me that if you're a NASH cirrhotic and you have varices, it's a different animal than if you have NASH without varices. This is the first study that showed a benefit in a subgroup of people with NASH cirrhosis, and it's hopeful that this drug can move forward into phase 3 development. JKB121 is a toll-like receptor 4 antagonist. Bottom line here, placebo worked better than drug, so this drug will not move forward. And then finally, the first shot at combination therapy. So here, this is a Gilead study combining the ASK1 inhibitor with either an ACC inhibitor or an FXR agonist. And ultimately, what we know from this interim data is that the combinations of these drugs are very, very safe. There wasn't a lot of signal at 12 weeks with combination therapy, but ultimately enough of a signal for Gilead to move forward with a 48-week paired liver biopsy study in phase 2. So more to come off this. And that wraps up my talk. I think we have 7 to 10 minutes for Q&A. I'm going to turn it back over to Jerry at this time, but thank you for your attention.
Thank you, Dr. Harrison, for that, as always, very informative presentation. I'd like to remind all the participants that you can enter a question into the questions pane on your control panel at any time. We are monitoring your questions. Now I would like to introduce Dennis Mash, our senior clinical specialist on the EchoSense team. Dennis has been assembling all of the questions, and Dennis, please read the first one to Dr. Harrison.
Okay, Dr. Harrison, the first question, when and under what conditions would you choose to use the NASH CRM published high sensitivity, high specificity threshold or blended threshold values?
Yeah, that's a good question. I like to use this in combination. I don't like to look at things in isolation. I think they're best used when we combine all the tools that we have available in assessing a fatty liver patient. I think what I like to look at first is if I'm trying to exclude patients. meaning 80% of fatty liver patients are going to grow old with their disease and don't necessarily need treatment, then what's that number that's going to make me have a comfort level that the patient is not going to have disease? And for me, that's the 6.5 number, somewhere between 6 and 6.5. Because I think if they're lower than that, the probability of having anything that is going to bother that patient in the long run is very low. Now, again, I don't use that in isolation. I like to look at the AST as well. If the AST is less than 20 and the KPA is less than 6.5, I feel very, very confident that that patient has disease that is very unlikely to progress, and we can really focus hard on diet and exercise. Alternatively, I like the balanced number, 8.5. That gives me pause for concern. Now, then I look at the AST. If the AST is above 20, and ideally more than 30, that really gives me pause that something may be going on. In fact, there's some data that we presented recently looking at FibroScan and AST cut points. If the AST divided by ULN is greater than 0.75, that puts the patient at significant risk of having NASH with some degree of fibrosis. So an example of that would be an AST of 30 with a normal, upper limit of normal being 40. That gives you the cut point of 0.75. So to summarize, if I have a KPA of 8.5 and an AST of 30, that puts me at a high likelihood of having NASH with some degree of fibrosis.
Very good. Thank you, Dr. Harrison. Dennis, next question, please.
Okay, Dr. Harrison, I'm going to combine a couple questions that have come in together. The first of which is, how should we use CAP clinically? And then to complement that, what CAP score would translate to a PDFF of 10%? And then what CAP score will translate into MRI PDFF of, well, 8%?
Yeah, okay. So ultimately, what we learned from the data that I've generated here in San Antonio from that study I showed you at Brooke Army Medical Center and now from the NASH CRN is really 280 seems to be the sweet spot, right? And that correlates with a PDFF of 5%, meaning 5% PDFF fat tells you have fatty liver. That's now kind of the gold standard. The correlatory CAP score would be 280. Ultimately, for 10% PDFF fat, you need to be around 320. For 8%, around 300. So the cut points I use, and these are relatively, arbitrary, 280 for fat, 300 for PDFF of 8, 320 for a PDFF of 10%.
Very good. Dennis, next question, please.
Okay, the next question is, should we be checking for fatty liver disease in our HCV patients?
Yes, I think it's important to check for fatty liver in HCV patients that have achieved a sustained virologic response if the ALT and AST remain elevated or they have risk factors for fatty liver disease, mainly obesity and type 2 diabetes, or a family history of fatty liver disease. It's not uncommon for us to treat hepatitis C. We've all gotten very good at it. The treatments are simple. 8 weeks of Maverick gives you a 99% cure across all genotypes except 3, and then we just have to treat a little bit longer. Or a well-compensated cirrhotic, we have to treat a little bit longer. But ultimately, it's not unusual for my clinical practice to treat and cure the hep C, but still now I'm dealing with residual fatty liver disease. If you talk about hep C and fatty liver, it's really genotype 3 that gives you fatty liver as a result of hepatitis C. If you cure hep C in a Geno 3 patient and that's the reason for their fatty liver, the fatty liver should go away. If it's residual, it means there's another reason for the fatty liver, and that's either alcohol or non-alcohol.
Very good. We have approximately 1 to 2 minutes left. Dennis, if you could read the last question, please.
In the absence of a fatty liver drug, how do we manage fatty liver today?
Well, I think, you have to become a cheerleader for lifestyle modification. clearly the data is there that they will derive benefit. I come into the room and I tell them frankly, jokingly, I say there are 4 words you need to know from me today, and that is eat less, run more. And then I build off of that and I say, well, here's what we need to do. We need to cut the processed carbs. And I force it. Everybody wants a detailed diet. They want to see a nutritionist. They want to have a sheet that I hand out that's very detailed. But what I tell them is just remember these things. Do not eat potatoes, any potato. That means Chick-fil-A waffle fries, chips, baked potato, au gratin potato, sweet potato, you name it. Bread, white bread, brown bread, Ezekiel bread. Everybody wants to get by with, what about this kind of bread? No, it's no bread. Tortillas, corn or tortilla or flour, and then rice. Brown rice is just as bad as white rice when it comes to fatty liver. It may have a lower glycemic index, still gives you fatty liver, and of course fried rice as well. And then pasta and pizza. If you can cut out those carbs, and sometimes I tell people, you know what, go celebrate one meal, not a day, go celebrate one meal per week where you break those rules, but ultimately you adhere to that carb restriction, you will lose a lot of weight. I'm not telling you to go Atkins. You can still have fruits and veggies, which are loaded with carbs. I just don't want you to eat those processed carbs I just mentioned. And then I tell them to exercise. And really it's about building lean muscle mass. Every year that you get older, particularly at age 50 and older, you lose about 4 pounds of muscle and you gain about 4 pounds of fat. So your metabolism begins to slow down. So you want to begin not only to get on a treadmill or walk or swim or elliptical machine or a bicycle, but you also want to build lean muscle. So you want to combine a little bit of aerobic with anaerobic work, and you also want to combine that with a hypocaloric diet that really is restricting those processed carbs. If that doesn't work, you could try vitamin E at 800 IUs a day, or pioglitazone up to 45 milligrams a day. Both of those have their individual concerns, but short of a clinical trial, that's my track on how to treat these people.
Very good. Thank you, Dr. Harrison. Joy, would you like to make the closing comments?
Yes, thank you so much, Jerry. This concludes today's webinar. On behalf of EchoSense, I'd like to thank Dr. Harrison for his wonderful talk on this very important health topic, and of course to you, our listeners, for your attendance. Thank you so much and have a great rest of your day.